Today what I'm going to talk about is a disorder that's pretty common in the elderly, Paget's disease of bone. Can everybody hear me okay?
Closer to the mountain.
See, I'm going to start with a case presentation today. An asymptomatic 81-year-old male with a history of hypertension and DJD, that's degenerative joint disease, presents with an abnormal prostate exam and an elevated PSA. His other lab tests, he has a slightly high alkaline phosphatase, a creatinine that's a little bit elevated at 1.7, and he has a prostate biopsy because of the concerns about cancer, and indeed he has prostate cancer. A bone scan is performed to rule out bone metastases. So again, there's concern that maybe his cancer spread to bone, but here's what the bone scan shows. Some really unusual findings. And this bone scan is normal except for the uptake here in the pelvis and here in the humerus. And basically this report was read as findings on the bone scan are consistent with Paget's disease of bone or metastatic cancer involving the right hemipelvis and left humerus, okay? Now, if you know anything about cancer and how it spreads to bone, this isn't cancer. This is just Paget's disease. But this case makes a few really good points about this disease. Number one, 80% of patients with Paget's disease are asymptomatic. So they're usually picked up incidentally on bone scans or x-rays or lab tests. You know, liver function tests are done fairly routinely, and alkaline phosphatase is part of that battery of tests. And when it's elevated, that's how Paget's patients are often picked up. Another thing this points out about Paget's, the involvement of the skeleton is focal. It doesn't involve the whole skeleton like osteoporosis. It just picks out certain bones. And in this case, you see that only 2 bones are involved. And the bone enlargement that you see here is also a very specific finding for Paget's disease of bone. If you look at this patient, if you compare the right side of the pelvis to the left side, you see how much bigger the right is. And you really see that if you compare his left humerus to his right humerus, okay? So again, a very typical case, and we're going to talk about this disease in a lot more detail today. Now, it's often said that Paget's disease of bone is the second most common bone disorder in the United States, behind osteoporosis, okay? But that's not really true. Do any of you have a patient with Paget's disease of bone that you've followed? If you have a patient, put your hand up. Because when I talk to crowds of doctors, they see very few patients with Paget. So again, it's not as common as we've been saying for a while. There's a lot of other bone diseases that are more common. So Paget's might be in 5th place. It might be down even lower. It's not that common. But it is the most interesting bone disease of all, and I hope to show that to you in the lecture today. And I think all you need to do is look at bone scans. You'll never see more interesting bone scans than in patients with Paget's disease. And here's 6 different patients. This patient has only 1 bone involved, the femur. Again, this patient just has the right side of the pelvis involved. In this patient, it's just the skull, not the mandible, but the skull, what we call the calvarium. This patient over here has the scapula involved, a vertebrae, and the sacrum. This patient has part of the skull involved, a real interesting appearance here, also the scapula. And this unfortunate patient has almost every bone in the skeleton involved. So you see there's a lot of variety in what Paget's disease looks like, clinically and on bone scans. And just to tell you some general things about the disease, it's a disease of the elderly. Most patients are over 50 years of age, well over 50, and rarely do they present under age 40. By the way, in your handout, what I want you to do, just look at that first page of the handout, the summary sheet. There's a lot of information in that big long handout, but most of it is more intended for doctors. I want you just to follow along on that first sheet that says summary, okay? And again, you see the figure that Paget's affects about 2% of patients over age 65 in the United States, but I think that's a big overestimation. And another interesting thing, Paget's occurs in different parts of the world, but a number of studies have shown that its prevalence, its frequency, has been decreasing over the past few decades, and we'll say more about that. Again, it's an uncommon disease in clinical practice, but an important one to know about if you're taking care of geriatric patients. The male to female ratio is about 1:1, and the worldwide prevalence is interesting. Because when you look at where Paget's is most common in the world, The epicenter, the place where it's most common, is Great Britain, okay? And the other areas of the world where it's common are countries where people migrated from Britain, like the United States, South Africa, Australia, and New Zealand. It's very rare in Asia and India, okay? So an interesting worldwide prevalence. Now, the doctor that first described this disease was Sir James Paget, an Englishman. No surprise, since this disease is most common in Great Britain. And this is a picture from his original report, a real nice illustration of a typical patient with Paget's disease. You see enlargement of the skull, enlargement of the tibia, and what we call bowing deformities of the femur and tibia. And Sir James Paget called this osteitis deformans because he thought it was an inflammation of bone. That's where that itis comes from. Now, since then, we know that it's not an inflammation of bone, but we're not sure exactly what causes Paget's disease. And the theory right now is it's a combination of infectious and genetic components. And the current hypothesis is that Paget's disease is caused by a slow virus that affects osteoclasts in bone in a genetically predisposed host. So you have to have the bad gene to begin with. And on top of that, you need a second hit. Apparently you need to get a viral infection, and that probably occurs very early in life. Now, where did this virus idea come from, this slow virus? Well, if you look at the osteoclasts from bones that are involved with Paget's disease, and you look at the nucleus of the osteoclasts, you see these strange particles and structures. And if you look at them even closer, they're filamentous like this. And they look like viruses, okay? That's what viruses look like under the electron microscope. And if you take those and you do a procedure called immunostaining, you find that those particles, they basically cross-react with antibodies to viruses like measles virus, respiratory syncytial virus, and canine distemper virus. And a lot of studies have been done on these osteoclasts in Pagetic bone, and they found pieces. They found pieces of these different viruses, but they've never found intact virus. So this remains a theory. It hasn't been proven yet. But another thing that supports a possible infection is that the decreasing prevalence in different parts of the world. There's less Paget's now than there used to be in the United States, in Great Britain, in New Zealand, and in Europe. So maybe that has something to do with vaccinations and the viruses being less frequent. But again, it's a hypothesis. We're not sure of that. Now, what about the genetic part? Well, evidence to support a genetic part to the etiology. Number one, the ethnic differences we talked about across the world. Okay, and another thing, up to 40% of patients with the disease have at least one first-degree relative that also has it. And in those families, it appears to be transmitted as an autosomal dominant trait. And a lot of studies have been done looking at genes in Paget's disease, and what's been found out basically is that a lot of the patients have mutations in a specific gene called the sequestosome 1 gene, which is on chromosome 5. Abnormalities in this gene, mutations have been found in now up to about 50% of patients with the familial form of this disease, okay? So it looks like there's familial forms of Paget's and then non-familial that we call sporadic. So that's what we know about the cause. And again, there's still a lot that we don't know. Now, before we go any further with Paget's, I want to talk a little bit about normal bone remodeling. Let's talk about what happens in normal bone before we talk about the abnormalities of Paget's. Now, when you look at a piece of bone, it doesn't look very exciting. It doesn't look very dynamic. But bone is constantly turning itself over. Old bone is being resorbed and replaced with new bone. And what that looks like on the microscopic level, you start with trabecular bone here, say in the pelvis. Osteoclasts move in and resorb bone. Again, this is a normal process. The osteoclasts resorb bone, and then they get out of the way. The osteoblasts move in, and they form new bone. So this is how bone keeps itself strong. This is how little fractures and stress fractures are repaired. And this is called the bone remodeling cycle. And it constantly happens over and over again, all over your skeleton. And another interesting part of normal physiology is the coupling of bone resorption and bone formation. If you increase bone resorption, if you increase osteoclast activity, in response to that, the osteoblasts will also increase their activity. So you have this coupling, this matching of resorption and formation. Likewise, if you lower bone resorption, the osteoblasts will respond by lowering bone formation. So that's what we're talking about when we say the coupling phenomenon. Okay, and that's real important in Pagets. You know, there's trabecular bone and cortical bone. The same process occurs in cortical bone, but it looks a little bit different. The osteoclasts get together, they burrow this hole down into cortical bone, the osteoblasts follow behind, and they lay down new bone. So that's bone remodeling in cortical bone. So what is the pathogenesis of Paget's disease of bone? Okay, and it looks like the primary problem is in the osteoclasts. Again, we talked about maybe that slow virus infection, specifically of osteoclasts. Because when you look at the osteoclasts in Paget's disease of bone, they're increased in size, in number, and their activity is also increased. And osteoclasts are multinucleated cells. Okay, they contain a lot more than one nucleus. But a normal osteoclast only has about 10 or less nuclei. In Paget's disease, the osteoclasts, you'll see them with 20 to 25 nuclei. So they're very abnormal. Okay. Now, the osteoblasts look normal in Paget's disease, but again, they increase their activity in response to the increased osteoclastic activity. And when they increase the formation of new bone, the new bone is disorganized. It's structurally inferior. It's not as strong as regular bone. And so basically, the new bone is increased in quantity, but of poor quality. And sometimes it's called woven or mosaic bone. And so just to kind of simplify that in a little summary, when you have a bone involved by Paget's disease, you have excessive bone resorption, that's followed by excessive bone formation in response. But the new bone, even though it's larger, it's a lot weaker than regular bone. Other findings in Paget's disease, the bone tends to be a lot more vascular than normal bone. And often there's more vascularity, which is more blood flow in the surrounding tissues. And this can be a problem for surgeons when they have to do surgery on pagetic bone. There can be a lot of bleeding, a lot more so than usual bone surgery. And as we've shown, the skeletal involvement, again, it's focal. Paget's, for some reason, just picks out specific bones. It doesn't involve the entire skeleton. Now, what I want to do is look at Paget's on the microscopic level and then take you up to the macroscopic level. I think it's important to understand this, you know, if you want to understand the disease. And if you look at normal bone, this is bone back here, calcified normal bone. And this is a normal osteoclast right here. It's sitting on the bone and resorbing it. And you see it's got about 4 nuclei. And here's some other normal osteoclasts here. Now, this is pagetic bone. Here's the bone here. These are 2 huge osteoclasts, and you see there's so many nuclei in these cells you can't even count them. So they're big, and they're abnormal. Now, when you look at regular bone, normal bone, and pagetic bone, this is cortical bone. Normal cortical bone looks nice and organized. You have these haversian systems, which give you a nice, strong bone. But with Paget's disease, you have this disorganized bone, called woven bone or mosaic bone. Kind of looks like a jigsaw puzzle with all these little lines. But you see that there's more bone here. When you compare this to this, there's more bone, but it's not as strong. Structurally, it's weak. When you look at trabecular bone, here's normal trabecular bone. Pagetic trabecular bone, again, looks very abnormal. It's thicker, but it's disorganized. Sometimes the term chaotic is used to describe the activity of the osteoblasts and the new bone that they lay down. And if you look under the scanning electron microscope at trabecular bone, this is nice, normal trabecular bone. This is what pagetic bone looks like. Again, thicker, but obviously not very strong looking. And you see these holes. What these holes are those, you know, conglomerations of those big abnormal osteoclasts just chewing away at bone. So much more bone resorption than normal. The response to that is more bone formation, but the new bone is weak. Looking at bone on the macroscopic level, this is a tibia, which is your shin bone involved by Paget's disease. You see how much thicker the bone cortex is than usual, but because it's weaker, you see this bending, this bowing deformity that leads to fractures here and here. And this is a femur, the thigh bone. You see the increased blood flow that is sometimes seen with Paget's disease. And then finally, when you look at x-rays, it's kind of predictable what we're going to see on x-rays. This is an x-ray of the femur, the thigh bone, and what you see is that the cortexes are very thick, but again, the bone's weak. And so first you get bending of the bone, you get a little stress fracture because the bone's brittle, and eventually that progresses to a complete fracture. Okay? So just to summarize all that, there's a paradox in Paget's disease. The bone that's involved is a lot larger than normal bone. Look how big that tibia is. The bone is thicker, but the bone is weaker. This leads to deformity and fracture. And it's interesting, when the tibia is involved, the deformity tends to be anteriorly. When the femur is involved, it tends to be a lateral bowing. So let's talk about clinical features of Paget's disease. Well, 80% of patients don't have any clinical features. They're asymptomatic, okay? And it's often picked up as an incidental finding on an x-ray, on a bone scan, or on routine labs. And often what happens is a doctor will get an x-ray for, looking for some other disease. He doesn't find the other disease, but just finds Paget's in an adjacent bone. Now, the 20% of patients that are symptomatic can have a variety of symptoms. Paget's can cause bone pain from the expansion of bone enlargement and deformity. This can lead to pathologic fracture, and you can get neurologic problems too. You can imagine when the skull is involved, when the skull expands and thickens, when the vertebrae are involved, when they expand, that can cause pressure on the brain or the spinal cord and lead to some serious complications. And also, Paget's can lead to secondary osteoarthritis, and we'll talk about that in more detail in a little while. Here's some illustrations of those problems, the clinical features. Here's a tibia with anterior bowing and deformity. Here's a femur fracture. And here's a patient with severe disease affecting a number of bones. You see her skull is involved, it's enlarged, she's losing her hearing, that's why she's wearing a hearing aid. She's in a wheelchair because she has a vertebrae involved that's compressing her spinal cord. You see, she also has tibial deformity, and that has led to osteoarthritis in this knee joint. Okay? So that shows you how serious the disease can be. Now, what are the most commonly involved bones? Well, the most common ones are the pelvis, the femur, and the lumbar spine. The pelvis is involved in 70% of patients with the disease. The femur in 55%, the lumbar vertebrae in 53%. Now, if you look at the group of bones that are the second most involved bones, it's the thoracic vertebrae, the sacrum, the skull, and the tibia. Okay? And a nice way to remember the three most commonly involved bones is that they're all connected. The lumbar spine, the pelvis, and the femur. Okay? Now, as far as classifying the disease, we talk about polyostotic and monostotic. 20% of patients have only one bone involved. And that can be a more difficult diagnosis when it's just one bone. But 80% have two or more bones involved, and we call those patients polyostotic. And these bone scans illustrate monostotic disease on your left, just the femur involved, and polyostotic disease over here. And look at how many bones this patient has involved. The humerus, both sides of the pelvis, the proximal femur, and both tibia. Okay, so monostotic and polyostotic. And obviously the polyostotic cases are going to be the worst cases. Now, other skeletal features of the disease, we talked about the most commonly involved bones, but Paget's can involve any bone in the skeleton. The little bones in the middle ear, the little sesamoid bones in some of your tendons, the patella, which is the kneecap. Paget's has been reported in every bone in the skeleton. Another interesting thing, it's very rare to see new bones involved after the initial diagnosis. So when you see that patient the first time and do their bone scan, those are the only bones that are ever going to be involved. If you see new bones involved later on, it's another disease like metastatic cancer. Now, what are the complications of Paget's? Well, complications can occur in the long bones, the skull, the vertebrae, and the joints. And we've already talked about long bone complications. Long bones like the shin bone, the femur. These complications are bone pain, bone deformity, and pathologic fracture. And there's a lot of colorful terms used to describe the radiographic findings in Pagets. And one of those terms is a banana fracture. Banana fractures can occur in the femur and tibia. And the reason they're called banana fractures is these bones start out with a bowing deformity, like a banana. They're shaped like a banana. And if you take a banana and break it along its convexity, first you'll get a little crack, a stress fracture, then it'll break straight across. And so that's what these bones look like when they're fractured. Another colorful term is the chalk stick fracture. Paget's bone is brittle, so it tends to break straight across. Fractures in normal bone tend to be diagonal. But again, if you break a piece of chalk, it doesn't break diagonally. It breaks straight across, and that's what gives these fractures this name. Let's move on to skull complications. When that skull is involved, when it gets thickened, what kind of problems can happen? Well, hearing loss is the most common complication of skull involvement. Other cranial nerves can also be compressed, including the facial nerve. Headaches can occur, and hydrocephalus can rarely occur with severe skull involvement. And this is what a normal skull looks like. You see the bone's not very thick, but when you have Paget's disease, you can have extreme thickening of the bones of the skull. Here's a CT scan showing, again, the extreme thickening that can occur with pressure not only on the cochlea and the auditory nerve, but on the entire brain in severe cases. Here's a patient that has facial nerve involvement. She has facial nerve involvement on the left side. The facial nerve exits the skull right around here, and that's why she has this loss of the nasolabial fold and this asymmetry to her face. Okay, so other cranial nerves can be involved. And one of the worst complications of skull involvement is when the base of the skull is involved and the bone softens to such an extent that the second cervical vertebrae can actually push up and put pressure on the brain stem. And this can lead to hydrocephalus, which can be a very serious problem. This problem often does respond to shunting. A shunt can be put in, a plastic tube that drains this fluid from the brain and takes it to the abdomen. Surgery in these patients would be very difficult and very dangerous. Paget's can also cause dental and jaw complications. Here you see involvement of the maxilla, which is your upper jaw. The rest of the skull is spared, and this is the kind of serious problems you can develop with the teeth. This patient has the mandible involved, the jawbone, and you can see how that shows up on the bone scan. So sometimes you can have the skull involved, sometimes you can have the mandible involved, or sometimes both will be involved. Skull involvement is a lot more common than mandibular involvement. Now, what about vertebrae? When you look at normal vertebrae here, you can see the kind of problems you can run into when Paget's disease affects a vertebrae, especially in this case where you have bone expansion backward into the spinal cord. And complications in the vertebrae, we talked about spinal stenosis, just squeezing of the spinal cord. You can get radiculopathy. Basically, those nerves that go out from the spinal cord also can be compressed by thick vertebrae. Compression fractures can occur because the vertebrae are weak. And then a very unusual and interesting complication, if the vertebrae are very hypervascular, if the blood flow is increased severely, that can actually steal blood from the adjacent spinal cord and cause problems like paraplegia, weakness of the legs. So those are the vertebral complications, and this is a normal vertebrae in the lower back, the lumbar spine. You see all the room there for the spinal cord. This is a vertebrae affected by Paget's disease. You see the expansion, the thickening, how that spinal canal is a lot smaller, and how easily the spinal cord can be compressed in a patient with this complication. Now, what about joint complications? We call this secondary osteoarthritis. Patients with Paget's are a lot more likely to get osteoarthritis, which is degenerative joint disease, if there's Paget's involvement of a bone that's near a major joint. And that happens for two reasons. Number one, those bowing deformities can put a lot of abnormal stress on a joint. And number two, since Paget's bone is softer, that bone underneath the cartilage of the joint space is a lot softer than it should be. And that can accelerate degeneration in a particular joint. Now, the joints that are affected, the knee, the hip, and the joints between the vertebrae and the lumbar spine. Here's an example of the tibia is involved, the shin bone. Here's the femur up here. You can see the abnormal stress that's being put on this knee joint by the deformity, okay? And here you see what happens if you have a normal femur and a pagetic tibia. This bone is supporting the weight of the femur, but it's soft bone. So the bone, the joint has a nice smooth cartilage coating, but underneath that cartilage, the bone is abnormal. That will promote degeneration of the joint. And that can be a special problem in the hip joint. In this patient, you see this pelvis is involved by Paget's. It's a lot bigger and thicker than the right side, okay? And this femur is also involved by Paget's. But the problem is here in this left hip joint, because this femur is normal hard bone, and what it's done, it's pushed back into this soft pagetic bone. So again, the bone under the joint is soft, and that leads to degeneration. Here you see a nice joint space. This joint's still pretty normal. You don't see any joint space over here. So that's a joint that needs to be replaced. And then here's an extreme case where that femur pushes into the pelvis because the bone is so soft on that side. So those are joint complications. Other complications we can see, if you immobilize a Paget's patient, you put him at bed rest after bone surgery, the blood calcium can go up, and it can go up pretty high. We call that immobilization hypercalcemia. But in a Paget's patient that's ambulatory, that's walking around, their blood calcium should be normal. Okay? There's a misunderstanding that Paget's patients have high blood calciums. That's only if they're immobilized. Okay? High output heart failure is a very rare complication that can be caused by vascular shunts within the bone. You need at least 30% of the skeleton involved to have this complication, and you also need to have some underlying heart problem. And finally, a rare but important complication is tumors. Paget's patients are more likely to have certain malignant tumors, okay? Osteosarcoma is the most feared complication of Paget's disease because it's an extremely malignant tumor that's very aggressive and very hard to cure. It occurs in about 0.5% of patients with Paget's, but it's such a rare tumor in adults that that's an increase of 30-fold in the risk compared to patients without Paget's disease. So whenever a patient with Paget's has new pain in a pagetic bone, this is one of the things we worry about. Other malignant tumors, fibrosarcoma, chondrosarcoma, and then benign giant cell tumors can also occur. And this is what osteosarcomas look like when they develop in pagetic bone. They have an appearance on X-ray that's called a sunburst appearance. So here you see one in the pelvic bone, and here you see one in the vertebrae. This vertebrae was involved by Paget's. An osteosarcoma occurred there. It's basically destroyed that entire vertebrae, and here you see it growing very aggressively outside the spine. Very few of these patients live more than a year when they develop this aggressive cancer. And here's what it looked like at the autopsy. Okay, so we've talked about clinical features and complications of Paget's disease. How do you make the diagnosis? What criteria do you need to say this patient has Paget's disease? Well, blood tests are very important, and urine tests are also important. And remember, we talked about bone resorption and bone formation. Which bone cells cause bone resorption? Does anybody remember? Right, osteoclasts. And it's the osteoblasts that form bone. And there's a number of different biochemical markers we can measure in the blood and the urine. And some of the markers are for bone resorption, some are for bone formation. So when we're measuring the activity of osteoclasts, we can look at things like the urine hydroxyproline and the urine N-telopeptide. These are breakdown products of bone collagen. Remember, in bone you have the calcium crystal, you also have the matrix, which is made up of collagen. So that's what we're measuring with these tests. Now, the osteoblasts make certain substances when they're active, and the most important one is alkaline phosphatase. Alkaline phosphatase is made in some other places, like the liver, but it's made in bone, and that's important in Paget's disease. And if you break alkaline phosphatase down, you can break it down into different fractions, like the bone fraction and the liver fraction. That's a much more expensive test, but sometimes it's helpful, and we call that the bone-specific alkaline phosphatase. But the most important of all these tests is the serum alkaline phosphatase. It's an easy test to get. It's just a blood test, and it's a very inexpensive test. One thing to remember, though, we talked about the normal phenomenon of coupling in bone, how the osteoblasts respond to changes in osteoclastic activity. When we're measuring alkaline phosphatase, again, we're measuring osteoblastic activity, but it's actually a very good measure of osteoclast activity because of that coupling, okay? And usually all we need to follow is the alkaline phosphatase because there's a very good correlation in Paget's disease. If you look at patients' serum alkaline phosphatase and their urinary hydroxyproline or urine N-telepeptide, you see a very good correlation between the two. And a blood test is much easier to draw and it's much less expensive than have patients doing 24-hour urine collections. So for diagnosis, all you really need is an increased alkaline phosphatase and classic findings of Paget's on X-ray and bone scan. It's very rare to need a bone biopsy. So if you're thinking about a bone biopsy in a patient with Paget's, you probably don't have to do it. Almost always, you can make the diagnosis with these three tests. Now, what are the classic features on X-ray? We've mentioned some of them. The main features are a thickened bone cortex, bone expansion, the typical sclerotic and lytic changes we see in Paget's disease, and the bowing deformities of the femur and tibia. And here's a real nice example of classic X-ray changes from the same patient. This patient has a normal right femur and a pagetic left femur. And right away you can see this bone is a lot thicker than this one over here. And the reason for that is that the bone cortexes are thicker. Here's normal bone cortex, and there's the thick cortex of Paget's disease. Here you see cortical thickening in a vertebrae. These vertebrae are often called picture frame vertebrae because of this appearance. And you see not only is the cortex thickened, but the bone is expanded. Okay? And it's interesting, when Paget's travels down a long bone, you see three phases, and those phases are labeled here. It starts off as a lytic phase. That's this black area that you see. And that travels down the bone. And the third phase we call the sclerotic phase. That's where the Paget's process has been the longest. And you see how white this bone appears in the sclerotic phase. So we have the lytic phase, the sclerotic phase, and in between we have the mixed lytic sclerotic area. Now if you look at this area 1 close up, that's what you're seeing here. You see the bone lysis that occurs, and there's usually this pointed front that's progressing down the bone. So that's the lytic phase. If you take a closer look at this area up here, that's the sclerotic phase. The bone is almost totally white, and then in between you have a mixture. So these are classic changes of Paget's. And here you see how the lytic phase of Paget's travels down a long bone, in this case the tibia. And if you don't treat this patient, this will progress at about 1 centimeter per year. You'll see progression. So again, the lytic phase down here, the sclerotic, and the mixed phase in between. These are classic X-ray findings for Paget's. Now it's real unusual to see pure lytic lesions without the other two phases. Sometimes you do, and that can be a difficult diagnosis. And that's often called the candle flame appearance or blade of grass. There you see it right there moving up the bone. Here you see it moving down the bone the other way. And here's an example of how if you see Paget's in that early lytic phase, it can be a difficult diagnosis. This is your shoulder bone. You know, you worry about other things, like cancer when you see this lysis, but if you wait a little while, a few years later, you see this lytic phase has turned to a sclerotic phase. Now the lytic phase is somewhere down here. Here's the lytic phase sweeping across the skull from left to right. Later on, it turns into a mixed and sclerotic phase. And when vertebrae become entirely sclerotic, sometimes they're called ivory vertebrae. So again, these are classic X-ray findings of Paget's disease. What about bone scans? The three most important findings on bone scan is you have intense uptake of the isotope. Also, the areas of bone that are involved are very large. Sometimes they involve the entire bone. Usually they involve at least 50% of the bone, okay? And also you see the bone expansion that we've talked about a number of times already. So this is what a normal bone scan looks like over here on the left. Here's a patient with polyostotic Pagets on the right. And you remember those three classic features we talked about. Intense uptake in the bone lesions. You see how that radioactive material is taken up intensely. Number two, the very large bone lesions. The entire pelvis is involved here. You look at the tibia, almost the entire bone is involved. 50% of the humerus, the femur and the tibia over here. So this is a classic Paget's bone scan. Cancer doesn't look like that on a bone scan. It's very specific for Paget's. And if you go back to that initial case that I showed you, a real good example of those classic features. Intense uptake on the bone scan, very large bone lesions, in this case involving the entire right hemipelvis, the entire left humerus, and when you compare to the other side, you see how significantly that bone is expanded. Now, this is what a vertebrae looks like when it's involved by Paget's disease. And again, you see because of the bone expansion, you have you have uptake outside of the normal contours of the spine. This has such a classic appearance, it's sometimes called the Mickey Mouse sign or the Clover sign. And just correlation of the bone scan and x-rays. Here you see a patient with involvement of the tibia right here. And when you get an x-ray of that area, you see the classic three phases that we talked about for Paget's disease. So again, you have the high serum alkaline phosphatase. All you need is the bone scan and the x-rays to complete the diagnosis. Again, here's an interesting patient. You see the findings, partial skull involvement on the bone scan, and you see the appearance on the x-ray. Both are diagnostic for Paget's disease. The only time to do a bone biopsy is if you think the patient might have metastatic cancer. Maybe it's a male patient with a high PSA test, an abnormal prostate exam. But again, usually you don't need to do a biopsy. Almost always you can make the diagnosis with the alkaline phosphatase, the bone scan, and the x-rays. The only other reason to consider a biopsy if you're worried that a tumor has developed, an osteosarcoma. That needs to be biopsied to make the diagnosis. Again, cancer, the differential diagnosis for Paget's, the question of cancer often comes up. Cancer usually looks much different on a bone scan. This is a woman with metastatic breast cancer. The cancer has spread to bone. You see there's small spots all over the place. So that's what cancer usually looks like. Very different from Paget's. Okay. And then it's a good idea to do additional laboratory studies. Once you've made the diagnosis of Paget's disease, to do the metabolic bone workup to make sure they don't have other metabolic bone problems going on. And the vitamin D is real important to check. Vitamin D deficiency is very common in the elderly. That can also elevate your alkaline phosphatase. So if you have a patient with Paget's that also has vitamin D deficiency, you want to get that treated. And basically, all Paget's patients should be on calcium supplements that contain vitamin D, especially if they're being treated for Paget's. So treatment is the last thing that we're going to talk about today. And we've really come a long way with treatment for Paget's disease. And the treatments that we use are treatments that inhibit osteoclast activity. I mean, that makes sense. The problem in Paget's disease is the osteoclast. So the best medication would be a medication that can slow down the activity of that particular cell. Now, bisphosphonate drugs are the drugs that we use now to treat Paget's disease. Calcitonin was the first treatment that we used 40 years ago but we don't use it anymore, okay? And both of these medications have potent anti-osteoclastic activity, a lot more so with the bisphosphonates. And the bisphosphonates that we use, these are drugs like Fosamax, Actonel, the same drugs that we use for osteoporosis, we also use for Pagets. But the doses are different, and I'll show you that in a moment. But basically, how do these drugs act? Well, number one, they bind very strongly to the crystal in bone, the calcium phosphate crystal that's called hydroxyapatite. Once they get in that bone crystal, they stay there for a long, long time. And the half-life in bone for these drugs is more than 10 years. The half-life in the blood is only about an hour, but once they get in bone, they basically can stay there forever. What they do is they not only inhibit osteoclast function, but they induce apoptosis of osteoclast. That's destruction or lysis of the osteoclast cell. And the way they do that specifically, they inhibit an enzyme called farnesyl diphosphate synthase. This is a very important enzyme in osteoclast. And basically, if you look at a normal osteoclast under the microscope, it has a ruffled border, and that ruffled border is where bone is resorbed. What bisphosphonate drugs do, they're shown here as red dots, they get into the bone. When the osteoclast tries to resorb bone, that bisphosphonate gets inside the osteoclast, inhibits the enzyme, and basically causes that ruffled border to go away and the osteoclast to become non-functional. And eventually, a lot of these osteoclasts will die because of that enzyme inhibition. So these are very good drugs for Pagets. Now, these are the names of the different bisphosphonate drugs. And basically, the chemical structure, pyrophosphate is a compound that we've known about for a long time that has a great affinity for bone. It stays in bone a long time. And you see it has this phosphate oxygen phosphate skeleton. Well, the bisphosphonate drugs have a very similar skeleton, but it's phosphate carbon phosphate. Because of that, once they get in bone, they stay there for a long time. And what makes the bisphosphonates potent, what gives them their efficacy, is the side chain, this chemical group called the R group here. And you see the different bisphosphonates have different side chains. And once you put an amino group in that side chain, the bisphosphonates get a lot more potent. And that's why, the list here are drugs that we use commonly for osteoclastic disorders: pamidronate, alendronate, which is Fosamax, risidronate, which is Actonel, and zoledronate, which is Zometa. And you see that when we go down the list, the potency of these bisphosphonates really goes up astronomically. Etidronate was the first bisphosphonate that we used for Pagets 35 years ago, but since then we've developed bisphosphonates with a lot more potency. And you see, Actonel as an example, 2,000 times more potent than etidronate in its anti-resorptive effect on osteoclasts. Now, when we give a patient with Paget's disease a bisphosphonate drug, we follow the biochemical markers. The main thing we follow is the alkaline phosphatase. But if you look at the other markers, like the urine hydroxyproline, you see that what happens first is that the urine hydroxyproline, or the N-telopeptide drops. These are 11 patients that were given a single IV dose of pamidronate. So first the osteoclastic function is inhibited, and then the alkaline phosphatase level goes down later on because of the coupling, okay? But eventually what you see here, these patients with high alkaline phosphatate levels normalize after one treatment with a bisphosphonate, and those levels stay normal for a long time. And we see a similar thing. These are patients with much more severe disease, just looking at their alkaline phosphatase, up in the thousands. After one treatment with risidronate, 30 days of PO risidronate, you see how nicely that alkaline phosphatase comes down and stays down for many months in the majority of patients. So that's one thing that's great about these drugs. Once we give patients one treatment, that treatment can last for a long time, 6 months, 8 months, sometimes years before we need to retreat them. And again, as you might guess, the more potent the bisphosphonate, the more likely you're going to normalize the alkaline phosphatase in patients with Paget's disease. With etidronate, you're only going to normalize it in about 15% of patients. But if you come all the way up to zoledronate, 89% of patients, you can normalize the alkaline phosphatase with just one treatment. And very few studies have compared these drugs directly, but this is the most important one of all, and it was published less than a year ago. This study compared zoledronate with risedronate. These are two very good drugs for Pagets. And what they did is they took 350 patients with Pagets. Their mean alkaline phosphatase was about 450. Normal goes up to 120. So these were patients with pretty severe disease. They gave half of them 5 milligrams of zoledronate. The other half they gave 60 days of oral risedronate. And you see the results over here. This is the alkaline phosphatase level, starting off at about 450. You see, these are both great drugs. You see how fast the alkaline phosphatase comes down in both groups. With the risedronate group, at 6 months, 58% had a normal alkaline phosphatase. With a risedronate group, 89% had a normal alkaline phosphatase. So that was at 6 months after one course of treatment. And here's the figures here. Now, when they followed these patients for another 6 months, looked at them at the 1 year mark for relapse, only one of the patients with zoledronate that responded had a relapse where the alkaline phosphatase came back up, whereas about 25% of the patients with risedronate had relapses. So zoledronate's a better drug in this situation. I would point out, though, zoledronate is not yet FDA approved for the treatment of Paget's disease. All those other bisphosphonates are FDA approved, but not zoledronate. It's expected to be approved within a matter of months in the United States. It is approved now in Canada and in Europe. Now, what about side effects? Well, when you look at side effects in the first 3 days, a lot of these patients treated with zoledronate had a flu-like syndrome, up to 50%. So it was a minor side effect, but this occurred a lot more commonly in patients given the oral drug. Only 5% of these patients had a severe side effect, and only 6% of the risedronate patients. But only one patient ended up in the hospital in each group, and no patients died in the study. So these are not only very effective drugs, they're very safe drugs. And often if you just give them Tylenol, you can do away with that flu-like syndrome that a lot of them will develop. One thing about Pagets, though, it's nice to see that alkaline phosphatase come down. That makes you feel real good when you're treating a Paget's patient. But it's just a number. Are we really affecting the course of the disease? And no study to date has proven that we can actually prevent or delay the complications of Paget's with medical therapy. But this is a trial that's ongoing now, the PRISM trial in the United Kingdom. They have 1,700 patients they've recruited with Paget's. They've randomized them either to symptomatic treatment, just treating their pain, versus intensive treatment to normalize their alkaline phosphatase. This is a 3-year trial. Results should be out later this year, and it'll be very interesting to see what this study shows. If we will get any proof that we're actually affecting the complications of this disease, the natural history. I'm just about out of time. We do have a lot of other evidence that these drugs work. We're waiting for the results of the PRISM trial. We talked about the effect on biochemical lab tests. We know that bisphosphonates improve bone pain in Paget's. That's been shown very definitively in previous studies. But another thing, surgeons have noted that there's a lot less bleeding of the bone when they give patients bisphosphonates before they do surgery on Pagetic bone. There's significant changes on the X-ray and bone scan after we use these drugs. We're just going to skip vascular steel. A few studies have been done looking at bone biopsies before and after treatment. Those studies have shown improvement. Just some examples. Here's an X-ray of the femur before treatment, and here's what it looks like after a year of treatment. So we do see radiographic improvement. Another patient, before and after treatment, improvement. Here's what a bone scan looks like before treatment in a patient with severe disease. After treatment, the bone scan looks much improved. Okay? And here's the bone biopsy studies, one of them. Here's Pagetic bone before treatment. 6 months later, it does look more normal. It does look more lamellar in this picture. So basically, why do we treat Paget's? What are the indications for treating it? Well, the best indications are listed here. Any patient with symptoms from Paget's disease should be treated with a bisphosphonate, okay? If they're asymptomatic, if they have involvement of the skull or vertebrae, that's an indication for treatment. If weight-bearing bones are involved, like the tibia or the femur, that's an indication. And finally, if they have involvement of bone adjacent to a major joint, especially adjacent to the hip or the knee, that's an indication for treatment. The doses that we use are different from osteoporosis. Residronate, 30 milligrams PO daily for 2 months. Pamidronate, a single IV infusion. Zoledronate, a single IV infusion. And then alendronate. We don't use it very much because you have to give it 40 milligrams a day, daily for 6 months, okay? And as far as treatment recommendations, basically the more severe the disease is, the more potent a drug that we want to use. And for mild to moderate disease, again, we make that determination based on the bone scan and the alkaline phosphatase. We're usually going to treat with either residronate or pamidronate, okay? For moderate to severe disease, we favor zoledronate, especially based on the results of the study that I reviewed with you. Basically what you do, you treat these patients, you follow their alkaline phosphatase, basically you follow it every 4 to 6 months, it'll go down. When it comes back again, when it comes back up, you treat them again, okay? And so basically that's Paget's. You know, we've covered it pretty thoroughly today. Just to summarize the things that I've gone over with you, what causes the disease? It looks like it's a combination of genetic factors and infectious factors, probably a slow virus. What are the clinical features? Well, bone enlargement and weakening of the bone. What are the complications? The main complications: pain, deformity, fracture, and neurologic complications from skull and vertebral involvement. How do we make the diagnosis? Serum alkaline phosphatase, x-rays, and a bone scan. And the treatment that we use, bisphosphonates, and follow the alkaline phosphatase. And the most important point of all, although it's increasingly uncommon, Paget's disease is still the most interesting of all the bone disorders, at least in my opinion. So I don't know if we have time for questions. If we do, I'll be happy to take them. Thanks a lot for your attention today.
I think you're more hungry than curious.
Yeah, I'm sure it was a long morning.